Thank you, Mr. Chairman. Ladies and gentlemen, it's really a great pleasure to be here in this beautiful place, and I thank Professor Enzo Bonà for the invitation and to bring all of this together. Yesterday evening was wonderful, and I look forward to the rest of the day. This is really, really amazing, and it's especially special to be in the same session with you, Simona. So, Mantua is beautiful. Utrecht is different. At least it's more rainy and sometimes grey, but if you are in the neighborhood, you might want to take a look, and if you then take the tram all the way back here to the university, you're welcome for a cup of coffee in my office. These are my disclosures, and these are the agencies that grant and support our work. I would like to take with you a very clinical perspective on cognitive dysfunction in diabetes and address the question that this gentleman is having, the concern that he is having about his memory, and the thoughts that this physician has about addressing these questions. So what I want to do is today with you address what we know about the scope of the problem of cognitive dysfunction in diabetes, discuss known risk factors and etiology, recent advances in treatment, and in particular discuss with you how that translates to current clinical practice in terms of diagnosis, screening for cognitive impairment, and patient management. And most of what I will be speaking about today concerns type 2 diabetes, but if you wish in the discussion we can also address type 1. So let's first look at the scope of the problem here. If you think about cognitive dysfunction in diabetes, it's important that you realize that cognitive dysfunction, like maybe neuropathy, is not a single entity. So the main distinction to make is between subtle cognitive changes and frank impairments, including mild cognitive impairment and dementia. And the best framework to address these different stages is age. And this is a piece of Dutch folk art. It's called The Staircase of Aging. And you should realize that the subtle cognitive changes that are associated with diabetes really occur across all age groups, both in type 1 and type 2 diabetes. Mild cognitive impairment and dementia, on the other hand, also in diabetes, mainly occur in old age, with really an accelerated occurrence over the age of 60, and it's extremely rare in younger age groups. So, when we look at the subtle cognitive changes, we have tried to come up with definitions, and there's an extensive description in the Lancet Neurology. But the summary is that these subtle cognitive changes are reflected in changes from normal performance that have a magnitude of approximately 0.3 to 0.5 standard deviation units. And I realize that this is quite an abstract concept to you, but you can see it as the equivalent of a jet lag. When you have a jet lag, you feel mentally slightly less efficient, but people who are in contact with you will not even note mistakes. So these subtle changes may result in cognitive complaints, usually expressed mainly by the patient him or herself, but should not disturb activities of daily life in a sense that the cognitive changes really lead to major mishaps, because then something else is occurring. These, like I told you, these subtle cognitive changes can occur in all age groups, and the important aspect of it is that progression is very slow. So in a person aged 40, these subtle changes are not a pre-dementia stage. So they can be upsetting and they can be worrying, but they will be slowly progressive, at least if they fall in this group. Mild cognitive impairment is something else that's defined also in the dementia field, actually as a pre-dementia stage. And here, in an individual patient, you will find that there's clearly abnormal performance. So on cognitive testing, the patient falls outside of the range of what we consider normal. And this can involve the domain of memory, and then we speak of amnestic MCI, but also other domains, and that's non-amnestic MCI. This can give rise to complaints, often by the patient, but sometimes the people around the patient start to complain because things are not as they used to be. But by definition, in mild cognitive impairment, activities of daily life are preserved. So the cognitive impairment is not severe enough to make the person dependent on help from others. This occurs predominantly over the age of 60 to 65 years, and people with MCI can progress to dementia, but they also can remain stable or even revert back to normal. With regard to diabetes, it's clear from systematic reviews that the risk of MCI is increased. Moreover, people with diabetes and MCI are more likely to convert to dementia than people without diabetes. This is clearly the most impactful stage of cognitive impairment, dementia. And dementia is defined as impaired cognitive functioning affecting always, by definition, multiple cognitive domains. And there are generally complaints, and the deficits are severe enough, by definition, to affect daily life. So this is a cognitive handicap. This occurs predominantly over the age of 60 to 65 years, and cognitive decline is generally progressive over time. So this is a slide on the epidemiology of dementia in relation to diabetes, and this mainly concerns people with type 2 diabetes, because in the large epidemiological surveys there are few people with type 1 diabetes represented. And a recent update of this meta-analysis shows that the relative risk of dementia in people with diabetes is 1.7, so that's a substantial increase in risk. And this is clear both for a clinical diagnosis of Alzheimer's disease with a relative risk of 1.6, and even more so for vascular dementia, 2.3, and that's not strange because we know that diabetes is a risk factor for stroke. So if we take these different stages apart from age being a distinguishing factor, it's important to realize that the subtle changes are something that affect people with diabetes as a group. So the performance of the whole group is on average shifted a little bit to the left, and this subtle cognitive decrements is not due to the fact that some people really stand out. So it's a group phenomenon, and it's difficult to identify the individual patient that is affected. On the other hand, MCI and dementia are a condition that affect an individual, and you can make a diagnosis in an individual patient. Current guidelines on diabetes management ask you to focus on these patients, and I will come back to these guidelines later on. But the question is, of course, can we predict who of the patients with these subtle changes will go on to have more severe problems? And this can be done actually with relatively easy obtainable predictors that you all collect in clinical care. And they have been summarized in this risk score that we published 5 years ago. I'm just going to ask you a brief question on this lady, because she's 78 years old. She has had type 2 diabetes for 12 years. She has some complaints of incidental forgetfulness, but actually she's very active and engaged. She travels by train on herself, visits family, goes to the theater. She would love this place. She has had a periodic visit to the GP where her diabetes is well controlled. She does have proliferative retinopathy treated with laser. And 3 years ago she had a minor stroke, but she recovered very well. And last year she visited the emergency room for a hypo. And my question to you is, if you had to give me an estimate of her 10-year risk of dementia, what would the number be? Just shout the number. 10%, okay. So we have 10%. Who offers more than 10%? 35, for the gentleman in the back. 35. Anyone more than 35%? Anyone less than 10%? No, there we go, okay. So the risk model takes into account a number of predictors. Initially, we were trying in our research program to predict dementia by taking refined cognitive testing and taking MR scans. And this captures the variation that is entailed in the subtle cognitive changes. But it's not easy in this variation to pick up the people who do very poorly. So we thought we may better look at other complications and see who is vulnerable. And these are regular complications that are all in your records, and they constitute the risk score. And you can simply add the points with all of these features and come to a risk indicator. And that separates people with different risk fairly well. So the lowest category, and these are all people above the age of 60, have a risk of 5%, and the highest have 73%. And our nice old lady, if you add up her risk, she ends up with a 10-year risk of dementia of 73%. And that's clearly dominantly due to her age, because many people at this age have a high risk of dementia in the next 10 years. But some of the diabetes-related complications that she is having really substantially add to her risk. So we can actually, with this risk score, based on quite simple features, identify people at risk of dementia. And now there's a disclaimer. Don't try this at home. Yeah, we did not develop this to tell nice old ladies that they have a 73% risk of dementia, because that is useless and cruel. This was developed for research purposes, because when we design a trial, for example, to prevent myocardial infarction, we enrich our cohorts with people at high risk. And this has never been done for cognitive outcomes. So if we want to have a trial and we want to prevent dementia, we need to have high-risk people in our trial. So that is why this risk score was developed. And the risk score was developed to enrich your cohorts for people at risk of dementia, or compare people at high risk with people at low risk. So it's a research tool, but you may use it in clinical care for vigilance. Maybe you can help, this tool can help to identify who you should actually screen for cognitive impairment. So that's about the scope of the problem. Let's discuss briefly risk factors and etiology. This is a bit of a complex slide, but it shows that there are actually many factors that contribute to cognitive decline and dementia in old age. And this is not specific to diabetes. So some of them are, say, generic, and that you can see with the red arrows. So here you really should take a lifespan perspective. Dementia occurs at old age, but dementia occurs due to lifelong exposure to risk factors and protective factors. So what we know, even in pre-diabetic stages in the general population, that probably a healthy diet and physical activity have some impact in the long run on risk reduction, whereas vascular risk factors in midlife increase risk. The big arrows are the ones with the highest impact. We see that when you come in later stages of life, and the red arrows are again data from people without diabetes, but likely also apply to diabetes, that being active still reduces risk, but at late life, vascular risk factors do not appear to have such a strong relation with dementia as an outcome, and this is also not the case in the green circle for diabetes. We do know from some diabetes-related factors, and those are in green, that hyperglycemia, but also on the other hand, severe hypoglycemia increase risk, and so do clearly vascular complications. This is a slide from a systematic review, and it's a bit of a complex picture, but I will explain what it shows. It was on what we know about measures of glycemia in relation to cognitive and dementia and brain imaging outcomes. And this is, for example, on the relation between A1C and cognition, and the height of the bar reflects a number of studies. So this has been studied a lot. Blue means that the studies had neutral results. Purple means high A1C, poor cognition, and green the other way around. And what you see, it's about 50-50. And this means that there's likely an effect, but it's likely not extremely big, right? You also see that few studies have looked at predictors of dementia, and this is because this requires huge cohort of patients with diabetes to have the statistical power to address this. Fasting blood glucose, I would say quite a few studies with neutral results. What's interesting is, and this was discussed also in Simona's talk, glucose variability has not been studied a lot, but is actually in all studies that have reported about it quite consistently related to worse cognitive performance. This study, which is a post-hoc analysis from data from the Carolina Cognition Study published last year, shows why it may be difficult to relate A1C to cognition. This is based on 4,000 observations, and overall the effect is neutral. But, and this is something that you also addressed, Simona, relation with glycemia may not be linear. So if you take a median split of the A1C, you see that both low and high A1C are possibly not good. And I will show this this is easily appreciated in this figure. So people at the low end and people at the high end have worse cognition. This may reflect occurrence of hypoglycemic episodes, but we cannot really address this in this analysis because it has not been recorded in a standardized way. What's also important is that the effects are not equally distributed by age. So if we look at this effect of both low and high glycemia, it's much more evident in people above the age of 70 than below. And this may clearly be a reason why many of the previous studies showed variable results, because here with a study of 4,000 we have the power to look at these subgroups, but in many of the studies involved only 50 or 80 individuals, and then you will not be able to appreciate this. Another intriguing factor is insulin. For the sake of time, I will not go to in detail there, but there is a notion of cerebral insulin resistance, and therefore in relation to Alzheimer's disease, and therefore insulin is of interest. But here, I would say the studies are clearly undetermined at this stage. What is a tool to look at mechanisms is brain imaging. And this is just a summary slide showing a compilation of what we know from many imaging studies that have been performed. And what this slide shows is the number of studies that have been performed. So on the right reflects many studies performed, and on the y-axis it shows how severe this marker is affected. And what you see is that atrophy in relation to diabetes has been studied a lot, and is actually quite consistently related to diabetes. So clearly diabetes is associated with a slight reduction in brain volumes, approximately the equivalent of 4 to 5 years of aging. Lacunar infarct are clearly more common also as a chance finding in people with diabetes. The impact on white matter hypertension is a bit less. What is clearly affected are the white matter connections, and that links again to some of the things that may be seen in the retina. And what is not so clearly affected are, surprisingly, markers of microvascular damage in the brain, but they may require further study. Of course, I've shown you that diabetes is related to a diagnosis of Alzheimer's disease, and the question is, does diabetes actually accelerate Alzheimer pathology? And there are many animal studies that suggest that if you induce severe hyperglycemia, this affects the metabolism of amyloid and tau, the two main abnormal proteins in Alzheimer's disease. But actually, neuropathological studies, and this is a complex slide, don't support this. I will take you through this slide step by step. It's an autopsy study involving 500 people with diabetes and nearly 2,000 people without diabetes. And what this study shows is that actually none of the typical Alzheimer markers, are more common on autopsy in people with diabetes than in people without diabetes, whereas markers of vascular injury are more common in people with diabetes. We can also look at Alzheimer pathology, the underlying processes, non-invasively with new PET scanning techniques. And this is a study where they looked at midlife diabetes and late life risk of amyloid positivity on scans in people without dementia. And again, there's no relation with diabetes. So what explains this excess risk of Alzheimer's disease in people with diabetes as a clinical diagnosis? Apparently not Alzheimer pathology, likely mixed pathology, and likely neurodegeneration, also reflected in the lower brain volume that we consistently see plays a role here. Finally, moving to treatment. There is an increasing number of trials that has as a primary outcome, for example, cardiovascular events and death, who take cognition along as a secondary outcome. And one beautiful example is the Accord Mind study that looked at cognition as a secondary outcome in their trial that you know very well, 14 months randomized controlled trials in very intensive treatment compared to standard treatment. And after 4 months, there was no improvement. After 14 months, there was no improvement of cognitive functioning, although the rate of brain atrophy appeared to be slower in the intensively treated group. This is from the systematic review, and you cannot read all of them, but in fact it shows that all the trial results on intensive glycemic control were neutral. We have been addressing this in the Carmelina study that also has as a primary objective to study cardiovascular safety, but we also plan to look at protection against cognitive decline. So the main study included nearly 7,000 participants and randomized to linagliptin or a placebo. Eligibility criteria where that people had to speak a language from the Latin alphabet in relation to the cognitive testing, and had to have a normal cognition at baseline and an on-treatment follow-up assessment. We obtained 2 cognitive assessments 2.5 years apart, and we had a full on-treatment analysis set on 1,500 people. What we did is that because I said in the earlier slide that cognitive dysfunction in diabetes is not a unitary construct, we deliberately tried to pick out the people who did poorly. So we made a dichotomy of people with accelerated decline based on 2 cognitive tests compiled in one composite endpoint, and we looked how the people with accelerated decline were distributed across the 2 different treatment arms. And the results were unfortunately disappointing. They have just been published last month in Diabetes Care, that there's no benefit of linagliptin over placebo after 2.5 years. The results of the, sister study, Carolina, have been presented at EASD last month. Here, the comparator was glimepiride, and another difference with Carmelina is that the cognitive assessments were even much wider apart, 6 years, which is really a prolonged follow-up and is very valuable when we address cognitive decline. And also we had even more power with 3,000 people in the on-treatment analysis. But again, unfortunately, the results were neutral. So this is the relative risk with really no difference between the 2 treatment groups, and also no differences in pre-specified stratified post-hoc analysis. So that is really disappointing. So back to diagnosis. Let's address briefly, finally, the question of this gentleman. He's a 48-year-old lawyer, and he had type 2 diabetes for 3 years. He has memory complaints. He makes no mistakes at work, which is, of course, intellectually challenging work, working as a lawyer, but he finds his workload burdensome, and last week he forgot his wife's birthday, and that was, of course, that had impact on daily life. Right? Yeah. And this made him come to your office, and so how would you assess this gentleman? You say mini-mental. I will say that I would first look in the conversation if I find anything of problems with mood or any other interfering conditions, and this was not the case with him. And in fact, because you already know that he is working as a lawyer, he cannot have major cognitive deficits. Then things would definitely go wrong. So a mini-mental state examination is not going to help you here, because the number will be 30 or 29 or 28, and what have you learned? So if you think this is a real complaint, you better do a full neuropsychological examination in a patient like this, because then you get the true numbers that you can discuss with him. So in the evaluation, he had no signs of depression. Cognitive tests showed no impairment, although the actual test results were slightly lower than what you would expect from somebody of his age and with his level of education. So think what diagnosis you would give him. I will tell you, I would give him the diagnosis diabetes-associated cognitive decrements, because these complaints have been there for some time. There's no other good explanation. These kind of complaints fit with what we see at a group level for people with diabetes. And the good news for him is that we can answer this question with a quite clear answer, because it would be very unlikely, if he has been having these complaints for the past 3-4 years, that this is an early stage of dementia. Because of his age, the prior likelihood is extremely low. We have an alternative explanation, and the whole picture fits with the cognitive decrements. So we can assure him that this is very unlikely, but just like you, I cannot predict the future. So I would ask this gentleman to come back after a year to see how he is doing. Extensive scanning and other things will not deliver you a lot of extra information generally in these cases, but if you have an atypical story, you should definitely do additional investigations. So another patient, 84-year-old gentleman, memory deteriorated in the past 3 to 4 years. He gets lost, so his wife doesn't dare to let him go out alone anymore. And last week he took an accidental insulin overdose, and that is why they are in your office now. And how would you assess this gentleman? Well, for the sake of time now, I fully agree with your choice. Because here an MMSE is clear. I mean, here there's strong evidence for cognitive problems, and you don't need a full neuropsychological assessment to find out that something is wrong here, because you have a clear suspicion that something is wrong here. So the time course is essential. If this had been happening over the past 3-4 weeks and before everything was right, then of course the story is completely different. But if this is something that evolved over years and you have a low MMSE, the diagnosis would be dementia, because here is interference with daily life, and the most likely causative diagnosis would be Alzheimer's disease in this case. For management, I will move into the next couple of slides, because it's clear from the literature that cognitive impairment, like what the gentleman was experiencing, affects diabetes self-management, is related to an increased incidence of diabetes-related complications, including hypos. People are in the hospital more often. Also, in more subtle changes of cognitive impairment, like MCI. And there's a growing literature on this. And this is why the current guidelines recommend that in people with diabetes and cognitive impairment, treatment should be made basically more easy and less risky. So the glycemic targets are adapted, and you should try to simplify treatment. I like the advice of the Japanese Diabetes Society on this, because they make a specific distinction between people who are treated with drugs that are associated with hypoglycemia compared to people without, and they give different guidelines for that. So that is, if you Google that, that is a very useful recommendation for risk management, I would say. Because of this, guidelines suggest to screen for cognitive impairment. And I know, who of you screens their patients for cognitive impairment? I see no hands, so you're all in frank, complete violation with the guidelines, but well, that's life. The point is, these guidelines are very well, there is maybe scientific support, but we lack a real pragmatic translation, I should say. And I think this is what we need to do, because just saying that we should screen everybody and nobody does it is not extremely helpful. So these guidelines really need a further implementation to get them working in practice. So in summary, I've shown you that diabetes is associated with different stages of cognitive dysfunction that require a different diagnostic workup and have a different prognosis. Etiology likely involves multiple factors. There is no proven effective treatment, but likely physical activity and a healthy diet and adequate vascular risk factor management, like you already do, avoiding hypos and avoiding severe hypoglycemia, like you already do, is the best way forward. This is my research team and collaborators, which I would like to thank sincerely, and I thank you for your kind attention.
Thank you, Professor Biessels. Very nice overview and very interesting topic. Question from the floor?
Thank you very much for your interesting talk. So, if I'm right, there are some data showing that GLP-1 receptor agonists can give some benefit for people with Parkinson's disease. So I'm wondering whether this can be applied also for this other neurodegenerative disorder, and whether there are data on clinical setting or basic data that can support this.
Yeah, I agree with you that there's animal data, there's experimental data, there's some pilot data in Parkinson's disease showing this on GLP-1 analogs. But unfortunately, like I showed you, the trials with the DPP-4 inhibitors were negative at this stage. So, yeah. Yeah, they are not. I agree, they're not the same. So maybe there's room for other. I don't say that this is the final answer, but we had hopes, and the first hopes were not rewarded.
Okay, I got your answer. Okay, thank you.
Agostino.
Thank you very much. Very nice lecture and comprehensive. I have a couple of questions. One is, in the predictive score, would you consider also socioeconomic status, occupation of the patient, and so on a personal characteristics? And what about inflammation markers?
Yeah. I think that this predictive point is well taken. Thank you. I think that this predictive score can be substantially improved. What we did, we used retrospectively data from the medical records, and then we had no availability of such. But even if you would do a small cognitive screening test on top of taking the risk score and adding the factors that you add, you could make it even better, although it already distinguishes quite well. Yeah.
The other question is, in prospective studies, maybe with new drugs, would you consider functional NMR as a tool?
I'm really, I have to say, not a fan of functional MR. And this is because functional MR doesn't measure the function of the brain, but it measures the function of the blood vessels supplying the brain. So you have a double outcome, and many of the treatments that we give can affect in some way the function of the blood vessels, even if they don't have any benefit for the brain. And then they will give a different fMRI response, and then I'm not sure whether you have helped the brain. So that's my personal view.
And then the final point. None of the intervention studies like the Accord and so on was able to show any benefit on cognitive function. Now, you also were telling us that the glucose variability is unanimously thought to be a factor for progression of this kind of disorder. Could it be that in those studies, the agent used and the higher number of hypoglycemia in the intensive treatment arm could have affected the result, preventing us from seeing some benefit of honest, good, safe blood glucose control in the absence of hypoglycemia?
Yeah, you're probably right in that respect. This has been monitored extremely carefully, for example, in the DCCT for type 1 diabetes, and there they didn't find any negative effects, but this was in relatively healthy young people, and in older people, they seem to be vulnerable more vulnerable for hypoglycemic episodes. So really, tight glycemic control can be offset by effects of hypoglycemia, really, yeah.
Bonora.
You answered the question that I wanted to do about the lack of any effect in these trials comparing more stringent and less stringent control, including the last one in which the control was pretty similar, but the drugs were more related to hypos or less related to hypos, like in DPP-4 versus glimepiride. And but going back to the Accord and the other, in which the difference in A1C was pretty large and the number of hypos was pretty common, or let's say more common. My question is to you: did you expect an impairment in those with more stringent control? So I change a little bit the question made by Agostino. So we are old enough to remember the story of the recurrent hypoglycemia and the cognitive impairment. So if I compare a group in which one has stringent control with more hypos, all drugs, as compared to the other, I expect that there is some possible impairment of cognitive function. Did you expect that, or what? What do you think?
Yeah, I think that it's critically dependent on who you are studying in your trial. So if you have relatively young people, the risk of stringent controls may be less, and also the impact of the adverse effects will be less. So there it may be your boundary of safety may be much higher, and you may actually have benefit of avoiding the hyperglycemia. Whereas when you have older people, you have your margin of error on both ends becomes more narrow, and then likely, and this is why the guidelines recommend this, tight glycemic control is not going to be very helpful, because your benefit may not be in balance with risk.
Yeah. Another issue is that those studies were not that long, so it may be that the detrimental effect of recurrent hypoglycemia could be detected only on a long run. And I wonder, the Accord Mind could help, because that as it's end of trial,
it was
continuous follow-up.
Yeah. So Accord Mind was 40 months, 3.5 years, so decent. Yeah, and then they have not published all the cognitive results on that yet. But Carolina had 6.5 years. That's a decent follow-up. I think that also we should be maybe a bit modest, or maybe not be too early upset, because we try to achieve something now in the diabetes field that has not been successful outside the diabetes field. We see and this is preventing dementia. We have also in people without diabetes, no really proven way to prevent dementia. And this is possibly because this is a disease process that extends over 30 years. And we try to modify that by giving people 10 months or preferred favorite treatment, and nothing will happen, of course. So our way of thinking may need some nuance. Yeah.
Thank you very much for your nice lecture. I have two short questions. One about, I think it's Carmelina, the name. One arm was linagliptin, the other one was SU, which all of us today would consider like hell. Instead, it did prove, I think for the first time, no harm for cardiovascular safety. But there were, as expected, many more hypoglycemia episodes. By the way, Enzo, hypoglycemia is the only topic which is missing in your beautiful 7th Mantua workshop. So I very much hope that for the 8th workshop you will ask me to plan a good hypoglycemia session, because as you see, it is very important. Back to the question, was there any deterioration of cognitive function in the SU group versus linagliptin? This is the first question. Yeah. Second, in literature, we have a lot of evidences about association, cognitive dysfunction, and hypoglycemia, and we are all confused who comes first, because it could be either way, and I would like to know your opinion.
Yeah. So there are multiple questions in one question. First, the choice of the comparator to take glimepiride. That was decided by the company together with the FDA. This was really, they had first Carolina, which was placebo-controlled, and then the FDA wanted an active comparator. And, well, this discussion was clearly done by the diabetes specialist. I was not personally involved in that, and there may have been other choices, but I find it difficult to comment on that. With regard to glimepiride having adverse effects, well, actually the treatment results were neutral, and hypoglycemic episodes were recorded, but not in the level of detail that any hypoglycemia expert would have preferred. So where we have often very refined diaries on hypoglycemia in a study that is specifically addressing that, there's not a huge amount of detail on the hypoglycemic episodes in both trials. We did perform analysis on those. We didn't find that the effects were modified by hypoglycemia. But in these trials, these analyses may be a bit crude. And then your final question, I forgot. And so did you.
Renzo.
I would like to know your opinion, looking the problem from another side. Since brain relies on glucose as an energetic fuel, what do you think about the possibilities that moderate hyperglycemia may be beneficial?
Moderate hyperglycemia.
Yeah. Since aging is correlated with higher blood glucose.
In the short term, this is true. So this is an extremely complex topic that you address here. In the short term, this is true. So people have shown that if you ingest a portion of glucose, you have a short enhancement of memory. The idea is that it even may be mediated by the insulin peak, because if you block that, the effect is much less. It appears that on the longer term, this effect is not present and may be offset by chronic effects of higher glucose that are also seen in, for example, the retina. So that vulnerability of the tissue to prolonged high glucose does not make it a good idea to have long-term elevation of glucose for the brain. But short, very short, maybe. But again, the fluctuations also don't appear to be very, so this is difficult.
Stefano.
Thank you very much. Very nice presentation. The result of the intervention trial have been disappointing, and you pointed out very nicely with a number of different examples. However, at a certain point, you also pointed out the need to enrich the population with high-risk people. So, and you have a risk factor analysis there.
Yeah.
What if you do extract from Carolina, from Accord, those people that start off with a higher risk?
Yeah.
Do you still see no signal at all, or in those people you see? In other words, how much the potential effect is diluted down by the average population?
Yeah, thank you, Stefano. That's a very nice question. And actually, we did exactly that in Carolina, because the risk score was developed after Carolina, but before Carolina. So in Carolina, we had a pre-specified analysis exactly like you suggest, and it didn't make any difference, unfortunately.
Cerebrovascular disease?
Yeah, so what we had was we did not take to look at people with cerebrovascular disease as a separate group, but we had a stratified analysis in people with low risk and high risk. And the stratified analysis in the high risk people, like I suggest for the enrichment of the trial, still didn't show benefit.
Raffaella.
May I?
Okay.
And a pathophysiological point of view, as there are no signs of Alzheimer's disease, what do you think is the most suffering tissue? It is the nervous system or the glial cells? Because there could be a similarity with the peripheral neuropathy, in which the Schwann cells is the most suffering, and as an effect as a sufferance of neurons.
Well, your point is extremely well taken. If it's not Alzheimer's disease, what is it? I think that the concepts we have on the etiology of dementia are oversimplified. We think this patient had Alzheimer's disease and this patient had vascular dementia. If we look at post-mortem evaluation of people who have Alzheimer's disease as a clinical diagnosis, only 3% have Alzheimer's disease as a single pathology. And others have also vascular damage, synucleinopathies, Lewy bodies. And the glia has not even been addressed extremely systematically. So I think that by keeping thinking in single diagnosis, we have not helped ourselves a lot. We should look at identifiable, modifiable processes, and they may also be at the level of non-neuronal cells, obviously. Yeah.
Raffaella.
Thank you. I enjoy very much your presentation. You well know that to treat type 1 diabetes is always a compromise to try to reach a good metabolic control, avoiding hypo events. From the evidence base in the last years, from your experience as a researcher in this field, what would you say for young people that a lot in this here today? It's better in the treatment to pay something in terms of glycathemoglobin, but avoiding hypoglycemic events and glucose variability. If you think about cognitive impairment, do not consider other complications, just this one. To think it's better to pay a little more about glycathemoglobin, but consider more important avoiding hypoglycemic events and glucose variability.
Yeah, thank you. But you asked me maybe an impossible question, because you have a number of complications where high-quality trials have been done. And these trials have shaped the guidelines that you use to set your glycemic targets, to prevent these different other complications, and that's based on solid evidence. And I would not like to, based on a gut feeling about cognition, where the evidence is less solid, to give any recommendation on changing guidelines. I would think that is a bit. Yeah, so this I would regard for me as an impossible question to answer.
Jack.
Hi, I'm here. Excellent talk, really interesting. And I'm curious to hear your opinion on different aspects. I mean, we spoke a lot about glucose changes, hypo, glucose variability, and so on. But then I always heard many thinking about insulin and insulin resistance, which is another major characteristic of diabetes. So what's your opinion on this?
Yeah. So this is here you can give a lecture, a new lecture on its own on this topic, because people have noted that insulin resistance is present in the brain of people with Alzheimer's disease, even if they didn't have diabetes. And people are implicating, and we have heard this yesterday in your beautiful presentation, how hormones related to glucose metabolism affect the brain, affect cognition. So insulin may also affect cognition. And there are even trials where they give intranasal insulin to people with Alzheimer's disease to prevent further cognitive decline. The phase 2 trials have been positive, but we are still awaiting most results from the phase 3 studies, and I don't think that's a good signal. I think that it's too early really to know what will happen if you put extra insulin in the brain through the nasal route, because insulin may also affect the metabolism of amyloid and tau. So this is still a bit a black box, but it's something that is very intriguing to explore. I don't know.
Very, very nice talk. Thank you very much. Just a pre-prandial question. Yeah. Does the brain work differently during fasting than feeding? Because clearly the mix of metabolites that's presented to the brain is quite different. For example, there is a vast literature on the brain usage of ketones, which prevails in the fasting state as opposed to the fed state. So I was wondering, if you apply your techniques of assessment of cognitive function or dysfunction, do they differ in a person, the same person, when he is fasted or fed?
So now I finally have a question that I can give back to the whole audience, because I ran over time, so you are late for your lunch. So how do you think about your current cognitive functioning, so now you're in an almost fasting state? Yeah, I can only speculate on really answering your question.
Yeah, it was a joke, really. Yeah. And the other joke is that, do you have any experience or evidence on the effect on cognitive dysfunction of intensive, compulsive use of the smartphone?
That's a very good point. Okay, I think that we have had a very lively discussion, but the discussion is not finished.
Just a brief comment to Raffaella, because she was asking whether we should prefer avoiding hypoglycemia or avoiding hyperglycemia. Well, I don't have the answer to this complex question, Raffaella, but I am the example of 23 severe episodes of hypoglycemia within 1 year, sometimes ago, and you can nowadays make your own assessment of my cognitive function years later, so you will have your own ideas about this.